let's move on now to our final segment on triple-negative breast cancer. Remains a very challenging area. Of course, the development of immunotherapy and some successes in that area are very notable. So a couple of questions to start off this discussion. One for you, Ian, is the role of next-gen sequencing and using things like mutational burden, mismatch repair, or even DNA damage signatures. And then Hope, you can maybe then follow with some of the nuances of PD-L1 testing and what we know actually from the randomized trials with the different testings available.
Yeah, so I think we've already touched on some reasons why we should be doing next-gen sequencing, even on triple-negative cancers. As Joyce pointed out, there was some data suggesting that these cancers may be sensitive to drugs like neratinib if they have a HER2 mutation, and drugs like capivasertib if they have AKT alterations. So I think there's now evolving data for some of these, albeit rare mutations, that could give us a potential target. Right. And then there's the issues of knowing the tumor mutation burden. Is that going to be a predictor of response to checkpoint inhibitors? Mismatch repair also seems like in and of itself may be a target that confers sensitivity to checkpoint inhibitors. So I think we're getting to a point in 2020 that we should be doing next-gen sequencing in addition to PD-L1 testing, which is a good segue.
When would you do it in triple negative?
Yeah, so I think that's a good question. It's been coming up lately. In general, you don't have time to do it in a patient who's presenting with symptomatic first-line triple-negative metastatic disease. So I think the primary thing to do is figure out their PD-L1 status, and then while they're on their first-line therapy, assess their.
That's kind of what I do. That's kind of how I do it.
Germline, BRCA, other next gen.
I kind of do. That's how I do it too. It's very similar way that I do it.
The hypothyroidism, that's, and the turnaround has to be quick. You know what I mean? So, but
outside of a trial.
Yeah.
Yeah, I think that, it's interesting because now we have to decide what we're going to test for, and the hypothyroidism trials are treating around PD-L1. So if you were going on that trial, you wouldn't, the new trials, you do PD-L1 testing, but everybody gets atezolizumab. But our approved indication that we use outside of clinical trials is patients who have PD-L1 positive immune cells in the first-line triple-negative setting based on IMpassion130. And in that trial, where there was a 7-month improvement in survival in patients who had PD-L1 IC positive disease, the determination of PD-L1 positivity has been reasonably controversial because there are a number of tests depending on the specific immune checkpoint inhibitor. So 41% of patients were positive. We looked further in patients who had enough tissue to do additional testing. So, and in that group, 46% were PD-L1 positive, but otherwise they were fairly closely matched with the overall IMpassion130 population. And what we found was that PD-L1 still seemed to be the best determinant of response to atezolizumab, PD-L1 positivity as determined by SP142. And it's been interesting because, we're going to see a bunch of metastatic trials report next year with atezo and with pembro, and we'll see a lot more data on PD-L1 testing. So right now we have to use the approval, SP142, at least 1% positive. Doesn't seem to make a difference how positive it is for use of atezolizumab combined with nab-paclitaxel, but I think that we're going to see a lot more data in the future.
Right, but I think your data that you just referred to that you presented at ESMO, or that was presented at ESMO, was very reassuring that SP142, at least for now, is a good predictor of.
I think it's a better predictor than CPS.
Yeah,
I mean, that's the issue.
I think that's because
we're kind of replicating the lung problems that our lung cancer colleagues did for the last 15 years.
It seems as though even 263 and the CPS 22C3 antibody, it's a CPS, it's a score, the antibody 22C3, that they're measuring something different because in our modeling poster we presented here, they don't completely overlap. So even if you go up on the number like you do a CPS score of 10 or 20 and 1 being positive, you still are doing, the populations actually move apart as opposed to come together. So you're measuring something else, which is complicated. The one thing you know is no matter what you test, you can find a positive population who will benefit because SP142 population is encompassed within the CPS of 1.
But the question is CPS giving you a false positive
Well, in the
And then you're
metastatic
over-treating
setting.
somebody, you're over-treating somebody.
And then it ends up being very different in the early stage setting that we'll talk about in just a moment, which I think it makes sense based on the immune changes that happen from early to late stage disease.
I must say that, you know, it's really great that we have a lot of biomarker data, multiple IHC in the IMpassion130 study. I think that's been tremendously helpful. But while we're on that topic, there was some updated survival data that was presented, and perhaps we can comment on
Well, they didn't update.
no, at ASCO, not at San Antonio, I'm sorry. Updated survival.
It's the 7-month that I was mentioning earlier, and I
Yeah,
think
it's
we
still
went from
held.
10 to 7 months, still highly statistically significant. And at ESMO Asia this year, there was also a subset analysis of Asian patients that showed effectiveness. And interestingly, unlike some of our drugs like the oral tyrosine kinase inhibitors and others, there's not a big differential toxicity apparent between the Asian subset of patients and non-Asians. That are sort of a mixed bag. So, you know, in terms of immune-related adverse events. And the other thing that was interesting to me in IMpassion130, it seemed like we're seeing less immune-related adverse events overall, although it's hard because a big trial compared to smaller neoadjuvant data so far, but less than what we saw in the neoadjuvant setting. And so maybe your immune system is not so intact for immune-related AEs, but, you know, rash, hypothyroidism,
Well, that's
preceded
a
often
hypothyroidism.
by
You're
hyper.
reactivating subclinical. I mean, remember, from medical school, 20% of women probably have subclinical hypothyroidism
But we
that
do
we're
see-
reactivating
yeah,
by using the
We
IO.
see some life-threatening toxicity, and I always say to people, the key thing is any organ can be affected. And if you see something funny and it doesn't go away, and you haven't seen it before, it's immune-related, and so you should treat it. Because, you know, and people are saying, well, the hemoglobin is 6, do you think I should give steroids? And I think the issue is that, you know, you give steroids and then think more about it, because you're not going to hurt anybody from giving them if somebody's
It's
really
so
sick.
important to have clinical pathways, you know, for all of us that are in practice and seeing these patients. It's impossible to keep up with all this at an organic level, and so more and more now. And these pathways are available through many, many areas, through ASCO, through a variety of other agencies. So that's critical if you're treating these patients.